Hey everyone, welcome to this high-yield explainer covering anesthesia and acute coronary syndrome. I am so thrilled you're here. Look, we designed this session specifically for you, postgraduate students who are getting ready to absolutely dominate your fellowship exams. We've got a ton of truly groundbreaking updates to cover from the massive 2026 AHA and ACC guidelines, and we're going to break them all down piece by piece so you can retain exactly what you need to know for test day. So let's just jump right in.
Real quick, before we hit the clinical pathways, I need to share this standard disclaimer from the Anesthesia Learners Academy. This explainer is strictly for educational and informational purposes, guys. It's not a substitute for professional medical advice, diagnosis, or treatment. You always have to rely on your own clinical judgment out there. Okay, housekeeping done. Here is our game plan for today, tracking right along the perioperative timeline. We're covering 1. The 2026 paradigm shift. 2. Pre-op risk assessment. 3. Intra-op coronary physiology. 4. The medication playbook. 5. Diagnosing MENS and ACS. And finally, number 6. Secondary prevention takeaways.
All right, Section 1, the 2026 paradigm shift.
So the fundamental philosophical shift introduced in these recent updates is pretty huge. Basically, the days of isolated decision-making, they're totally over. I mean, with over 313 million surgeries happening globally every single year, modern care absolutely demands a collaborative, shared decision-making model. And honestly, this finally brings U.S. guidelines much more in line with the European ESE standards that have been pushing this team-based approach for a while now. You are no longer just an anesthetist working in a vacuum. You are a vital piece of an entire perioperative team. Moving right along to Section 2, Pre-op Risk Assessment.
Okay, spoiler alert for your exams. Routine stress tests for every single patient just to clear them for surgery are officially a thing of the past. Forget it. Instead, you need to memorize this 4-step framework. First, identify and stabilize any active, urgent issues. Think decompensated heart failure. Second, calculate the risk for a major adverse cardiac event, or MACE. Third, assess functional capacity, using objective tools, not just casually asking if they can climb a flight of stairs. The guidelines really push for the Duke Activity Status Index, or DASI, where a score over 34 links to a lower risk. And fourth, incorporate risk modifiers. Now, this is really interesting because risk modifiers are a completely new concept in these guidelines. You can kind of think of them as clinical red flags that the raw calculators completely miss. If your patient has severe aortic stenosis, significant pulmonary hypertension, or clinical frailty, their true risk is drastically higher than whatever that raw score says. Spotting even one of these should instantly trigger a team huddle and likely a plan for advanced monitoring.
All right, Section 3, intra-op coronary physiology.
Let's look at the physiological balancing act in the OR between myocardial oxygen supply and demand. Notice how tachycardia sits right there on both sides of this equation. It is absolutely your worst enemy. An increased heart rate drastically spikes oxygen demand, while at the exact same time, it decreases the time the heart spends in diastole, which, remember, is when the left ventricle actually gets perfused. It's a literal double whammy of ischemia.
So to combat that double whammy, commit these high-yield rules of thumb to memory. First, keep that blood pressure tight, within 20% of their baseline. Second, if they do drop and get hypotensive, you're reaching for phenylephrine over ephedrine. Why? Because ephedrine causes unwanted sympathetic stimulation and dangerous heart rate spikes. And third, if you're dealing with tachycardia that isn't just from pain, anxiety, or hypotension, use esmolol to bring that rate down safely.
That brings us to Section 4, the medication playbook. The new guidelines give us some crystal clear rules on holding versus continuing crucial cardiac drugs. And let me tell you, this timeline is heavily tested on boards. You absolutely must know the hard stop for SGLT2 inhibitors. Stop them 3 to 4 days prior to surgery to prevent severe euglycemic DKA. As for stents, if the patient had a drug-eluting stent for stable angina, you ideally want to wait 6 months before surgery, though 3 months is the strict minimum. But if that stent was placed for a myocardial infarction, the ideal wait is a full 12 months to prevent catastrophic stent thrombosis. Now, a massive shift here is how we handle ACE inhibitors and ARBs. The great debate? It's over. Yes, holding them can prevent intra-op hypotension, but continuing them is now seen as completely reasonable, especially for your patients with heart failure with reduced ejection fraction. It's no longer just a lazy blanket rule. You really have to make an individualized, patient-by-patient decision.
Okay, Section 5, diagnosing MIS and ACS.
Transitioning to the post-op phase, we run into one of the absolute biggest updates in the guidelines, MINS. This stands for myocardial injury after non-cardiac surgery. By definition, it's any elevated troponin after surgery from an ischemic cause. And here's the kicker you need to remember. This includes troponin bumps in patients who have zero symptoms whatsoever. None. Even a tiny, silent rise in troponin is a highly powerful predictor of 30-day mortality. We simply cannot afford to miss it.
So how do we actively catch MENS? Well, the new standard protocol dictates systematic postoperative surveillance. For your at-risk patients, meaning those over 65, or anyone with known heart disease having a higher risk surgery, you have to check a high-sensitivity troponin at 24 hours, and then you check it again at 48 hours post-op.
Now, let's say you do find an elevated troponin. You have to immediately differentiate a standard type 1 MI, which is your classic plaque rupture, from a type 2 MI. A type 2 MI is a supply-demand mismatch without any acute coronary thrombosis, and it's often triggered by things we deal with all the time in the ICU: sepsis, severe hypoxia, or tachyarrhythmias. This is highly testable because a type 2 MI does not automatically mean you start dual antiplatelet therapy or rush them to the cath lab. You have to treat the underlying precipitating problem first.
Let's move to our final section, Section 6, Secondary Prevention Takeaways.
To wrap things up, let's look at the latest secondary prevention guidelines for patients being discharged after an acute coronary syndrome event. Based on the 2026 Multi-Society Dyslipidemia Guideline, the targets have shifted super aggressively. Patients with very high-risk atherosclerotic cardiovascular disease now require management with an LDL target explicitly below 55 milligrams per deciliter. To actually get them there, you are very likely going to be using a high-intensity statin combined with ezetimibe.
Let's look at how this shapes your final discharge checklist. The main takeaway? Make it highly individualized. Prescribe that statin and ezetimibe combo. For beta blockers, long-term use is no longer a generic rule across the board. It's based strictly on their ejection fraction phenotype. It's great for reduced EF, but not universally needed for preserved EF. And definitely note this one. While it was briefly popular a few years ago, colchicine is not considered routine post-infarction therapy in the 2026 guidelines.
Wow, okay, we've covered a ton of incredibly high-yield ground today. So, I leave you with this final thought. As surgical complexity continues to increase globally, how are you going to champion this integrated, team-based approach to catch silent killers like MINS before it's too late? It's really all about moving past the old silos and elevating the whole field of perioperative medicine. If you found this explainer valuable for your exam prep, please do not forget to like, subscribe, and share it with your co-residents. Keep studying hard, and I'll see you in the next explainer.